Good afternoon, everyone. Thank you for joining us for today's webinar, New England Quality Care Collaborative. Before we get started, I wanted to just mention that this call is being recorded for training purposes, and the presentation is available on the event webpage. So before I introduce our speaker, I would like to thank you all for joining us and to welcome you to our webinar. This webinar is one of two webinars we have planned for you as a collaborative effort between the New England QuinnQIO and the Urgent Care Association. Part of our collaborative objective is to connect urgent care centers across the nation with the QuinnQIOs serving their state or region so that together we can improve the quality of care through spreading best practices and data-driven quality improvement initiatives. We will begin by sharing some contact information with you at the end of the we will be sharing some contact information with you at the end of the webinar to help you connect with each other. Another note, we will be having our second webinar on December 11th. Flyers will be coming out soon. For pharmacists seeking ACPE credits and the UCA CUCM participants seeking CME certificates, please make sure to complete the evaluation within the next 2 days and give us about 2 to 3 weeks to process your credits and certificates. I will now introduce our speaker. Dr. Joseph Toscano received his medical degree from Duke University School of Medicine in 1989 and trained in the internal medicine at the Naval Hospital in San Diego. He has worked in the areas of emergency medicine and urgent care for over 20 years. He has been an attending emergency physician at San Ramon Regional Medical Center in San Ramon, California since 1999 and is currently chief of the department. Dr. Toscano has worked in urgent care since 2005 and was previously a partner and corporate medical director for Pinnacle Medical Group, which operated 5 urgent care clinics in California and Arizona. In addition to caring for patients, he is a senior research editor for Emergency Medicine Practice and a monthly evidence-based emergency CME publication. He is a member of the editorial board for the following journals: Emergency Medicine and the Journal of Urgent Care Medicine. He also develops and reviews continuing medical education material in urgent care and emergency medicine for a variety of other publications and organizations. He has been an active member of the Urgent Care Association of America since 2005, has presented clinical topics at many educational conferences, and is currently the clinical content coordinator for UCA. He is a founding board member of both the Urgent Care College of Physicians and the Board of Certification in Urgent Care Medicine under ABPS. So with that, I will pass the ball over to Dr. Toscano to go ahead and get us started.
Thank you, Morgan. Let's see. Let's go to the next presentation. There we go. So I have some disclosures because some people will be getting CME for the participation here. I did get a one-time honorarium from a company that makes over-the-counter cough and cold medicine. The subject of my speaking with them really doesn't have anything to do with the current topic. And everything I'm going to speak about today is evidence-based. There are no off-label or experimental therapies or devices that I'll be discussing. Got a bunch of learning objectives. Going to cover a lot in the next hour. By the end of the talk, I hope everybody will understand that antibiotics are not all good. There are a number of potential harms every time an antibiotic is prescribed, whether it's prescribed appropriately or inappropriately. Even when we prescribe antibiotics appropriately, there is a downside, and when they're prescribed inappropriately, there's no reason for it. We'll talk about those harms. The flip side of doing things wrong is knowing how to do them right. I'm going to go through the recommendations of the IDSA, the American Academy of Pediatrics, and the American Association of Family Practice in terms of a number of infections that are commonly seen in urgent care and acute care practice. A lot of detail there. The purpose of that is not necessarily to have people learn it in an hour, but to examine your own practice. If it's in line with the current recommendations, then you're golden. And if not, then it's going to be important to go back and update your practice in accordance with those the current clinical practice guidelines. Um, those guidelines relate to the treatment of infections and also some antibiotic prophylaxis. Toward the end, I'm going to talk about a few situations where we, I think for many years, have commonly prescribed antibiotics that the newest evidence shows that we really don't need to. Kind of the low-hanging fruit that we could knock off the tree pretty quickly in terms of improving our prescribing practices. And then finally, I'll close with a few pointers on how to get patients to accept not getting a prescription in situations where they might have gotten them before. I think that's one of the main impediments to a change in provider prescription practice is the sense that patients aren't going to like it or they're going to be less satisfied. This is going to be a major part of the talk, the webinar that's going to occur on December 11th. Morgan had mentioned that in the introduction, and so I'm going to touch on it just briefly here, but there'll be a lot more information in the December 11th webinar if you could participate or watch it, the recorded version of that webinar after the fact. This term stewardship gets thrown around a lot. I mean, what does it mean? I think after a while we forget. And what it basically means is that we need to care for and be responsible with a resource. And in the case of antibiotics, it's a very important resource with a very high upside. We are able to help patients immensely by prescribing antibiotics appropriately, but a very low downside in terms of what can happen when too many antibiotics are prescribed inappropriately. The reason we have to do this careful and responsible management of this resource is the harms that are created by antibiotics. The CDC estimates that about 23,000 people die as a direct result of antibiotic resistance, and the cost is about $30 billion. And there's a lot of evidence that antibiotic prescriptions are inappropriate when this gets subjected to study. A lot of patients with viral infections like colds and bronchitis and viral pharyngitis end up getting prescribed antibiotics. The estimates range from 30 to 50% in terms of how many prescriptions are actually unnecessary but still given to patients. And then kind of tying this all together is the fact that antibiotic use and our prescription of antibiotics is the one thing that we can change. A lot of this is driven by biology. If a patient has a bacterial infection, they need an antibiotic. Antibiotic resistance develops over time. We don't really have much control over those things, but what we do have control over and how we can modify the current trend is to examine our use of antibiotics, our prescription of antibiotics, and then changing that. That's how we're going to get change. A couple of other summary points about the downsides of antibiotics. Many ER visits are related to adverse drug events related to antibiotics. If you look at the drugs that cause ADEs in children, at the top 10 drugs that lead to ER visits, 7 of them are antibiotics in that category. About 20% of ED visits for adverse drug events are antibiotic related overall. And then about anywhere between 5 and 25% of those patients receiving antibiotics will have an ADE. They may or may not need another medical visit for it, but it's very common. And then, again, the flip side to all the badness is the leverage that we get from doing things right. The CDC reports that they project that if we could decrease inappropriate prescribing by about 10%, there would be a 17% reduction in C. difficile infections. So that's almost a 2-to-1 benefit for a 10% decrease in inappropriate prescribing for that one harm. I think probably in general acute care practice, everybody sort of sees this, but some of these other multiply resistant bacteria are really the end result of our prescribing. We see these in the ED and in hospitalized patients, very sick patients. This is really what we want to avoid, these superbugs. And unfortunately, more and more urgent, serious, and concerning bugs are being added to this list over time. There's a paper, actually it was sort of a very brief report of a study. It was published just this past summer in JAMA Internal Medicine, and it showed the amount of inappropriate prescription. So anywhere from 14 to 45% of patients with viral diagnoses were prescribed antibiotics in the study during the study period. And the venue where it seemed to be most common was urgent care medicine. Although there were twice as many visits there as other acute care venues, although people's private physician offices eclipsed everything, the level of antibiotic inappropriate prescribing, at least according to the study, was high in urgent care. So it's become a focus for improvement and one of the reasons for this talk. Some of the other things, kind of wrapping up the harms of inappropriate antibiotic prescribing, are the fact that because an antibiotic is prescribed when it wasn't needed, the visit results in a higher cost, the cost of care for that one encounter. And then as well, when you start to tack on the costs of the adverse drug events, you have increased costs from that inappropriate prescription. In general, outcomes are not better from inappropriate prescribing. They are worse. Patients will get allergic reactions to antibiotics that they didn't deserve because they didn't need to be on the antibiotic in the first place. The most common ADEs or downsides to antibiotic prescribing are the GI side effects, which can be nausea, vomiting, diarrhea, which occur, and luckily most of the time will stop once the prescription is stopped. But some patients are left with ongoing harms, and Clostridium difficile is an example of one of those. I think in the last 5 to 6 years, concern about fluoroquinolone use and the harms fluoroquinolone use have markedly decreased our use of those in clinical practice, tendinopathies, QT prolongations, and dysglycemia, alterations in blood glucose levels, patients' diarrhea. With diabetes occur in patients taking fluoroquinolones. Renal insufficiency can actually be induced by antibiotics. And then, of course, in patients who are taking multiple medications, the chance of interactions is 0% if we don't prescribe anything at a visit. And then there's some finite percent in terms of the chance of an antibiotic causing an interaction with another medication that a patient's taking. And if it's an inappropriate or an unnecessary prescription, it's really an unnecessary percentage chance that really shouldn't occur. Also on this list, I didn't put it on here because it's not necessarily evidence based, but I just wanted to mention it as an aside, that antibiotic use is actually correlated, no idea what causation would be, but actually correlated with the development of type 2 diabetes. And there's similar data being reported from a variety of sources. It'll be interesting to see whether that's a true association or just a correlation. In Europe, sore throat is a non-disease. Actually, don't even worry about strep or other causes, and they screen for more complicated causes of sore throat, like parapharyngeal space infections. But in terms of worrying about strep or treating anybody with a plain old sore throat with an antibiotic, it really doesn't occur in Europe. And Europeans looking at our practice here, it was remarkable to them how us just caring for a patient with a sore throat and then prescribing antibiotics actually made the patient come back the next time they had a sore throat. So at least the European perspective on this is that a harm of prescribing antibiotics for sore throat is that people keep coming back every time they get a sore throat, and most of the time they don't need an antibiotic, so it sort of complicates it. In this study, they also found that there was absolutely no difference in the over 4,000 patients that were cared for in the study, whether they had antibiotics or not, or whether antibiotics were prescribed in a delayed fashion. So at least the European perspective on sore throats is that really the patients need a history and an exam to make sure it's not a more complicated condition, and then they just need to be reassured. Well, why would anybody even prescribe something inappropriately? I think there are a variety of reasons, and some of these are maybe a little bit outlandish, but you do hear them. I think many people sort of resort to the fact that they were trained to practice in a particular way. And, there's plenty plenty of evidence that about a year or two after we're done training, our practice is out of date and needs to be updated. So certainly our training is a good starting point, but not a reason to continue to do the same thing or to continue to do something that's out of date. A lot of providers fear a bad outcome for the patient when they don't prescribe an antibiotic. But in those situations where it's needed, that it may be the case, for sure. But in all of those cases where the antibiotic is prescribed inappropriately, there will be no good outcome as a result of the antibiotic. And the only thing there could be is a bad outcome because the antibiotic was prescribed. You need to really start thinking that way. Certainly peer pressure. I think if the people around you are doing something that's inappropriate, the threshold for you doing it is a little bit lower. It's not a valid reason, but one of the reasons why we need to involve our colleagues in getting educated about good practice as well. This issue of patient satisfaction keeps coming up, and there is some evidence that it's probably true. There's also some evidence that if most patients get an explanation about why they don't need an antibiotic, they'll be equally satisfied. But again, probably one of the most complicated parts of change in terms of our prescribing practices, and I'll talk a little bit about it later in this webinar, and then it will be the major part of the December 11th webinar in terms of how we can maintain patient satisfaction without prescribing antibiotics. I think some of the more outlandish and hopefully these will sound completely inappropriate to participants, but occasionally I've actually worked in practices where we had samples of antibiotics that were fairly broad spectrum. A patient needed a narrow spectrum antibiotic. The provider wanted to give the patient samples because it was less expensive, and they gave them an antibiotic that would certainly cover the infection that they had, but it was way broader in terms of spectrum than the patient needed, so subjecting them to all kinds of additional collateral damage and killing of bacteria outside the scope of infection unnecessarily. And then the last two, I think, if pharmaceutical reps are coming to the office and buying lunch and talking about antibiotics, it's not really a reason to prescribe that antibiotic unless it's guideline-based or evidence-based. And then finally, some practices actually dispense antibiotics, and that's certainly not a reason to give a patient antibiotics when they don't need one. Summarizing again why we have to change our practice. I hope everybody understands that and sees the evidence that resistance is rising, and that our prescribing leads to that as a direct result. In urgent care, a large proportion, and in acute care in general, when you think about what is prescribed, pain medication, anti-inflammatory medicines, muscle relaxers, and antibiotics are a large proportion of what's prescribed. And even though things are improving, there's still, whether you believe the 30% number or the 50% number or a number that's lower or higher than that, there's still unnecessary overprescription that's occurring, and so we need to try and make a dent in that. It is the case that, and I hope everybody today is here because they want to learn more, but education about doing things properly can reduce overprescription if it's applied in a direct and focused fashion. And I think we need to educate patients more. There's evidence that teaching patients about these sorts of things will help. It's certainly not something that happens quickly, but it has been demonstrated to be effective. And then finally, and leading into what I'm going to be talking about next, there are very clear guidelines for treating the infections that we see most commonly. The antibiotics that are used are very focused and narrow spectrum, and we need to keep to those guidelines to minimize problems and issues with antimicrobial resistance. What I'm going to speak to you about today, again, is evidence-based. These are the sources of information. A lot of the practice guidelines I'm going to speak about come from the Infectious Disease Society of America. The idsociety.org/practice guidelines is the URL to access those. Even the AAT and AAFP guidelines will show up on the IDSA site, so you can access them that way. And then finally, the Institute for Clinical Systems Improvement, the very last reference here, is a good source for putting together guidelines from a number of sources and sort of distilling them down. They have a nice respiratory illness guideline that covers bronchitis, sinusitis, laryngitis, and it's a nice summary of best practice for those things. I'm going to talk about some tools. Again, I'm going to get into a lot of detail about the specific antibiotics that are used in specific cases, or I'm probably not going to talk about it too much, but just show everybody. But there are some tools, which I'll talk about next, that can put all this information at your fingertips. You don't have to memorize it. The adult and pediatric compendia that are put out by the California Medical Association Aware Foundation, the Alliance Working for Antibiotic Resistance Education, are available at the URL at the very top, and I'll show you some examples of those coming up. It's a nice tool. So actions right here. It's hard to read this, and again, the purpose is not for you to read this, but to know that it's available. Again, at the URL on the last side at the very top, these are front and back, and they summarize common infections as well as the evidence base for those. They come in adult and pediatric versions. There's a lot of overlap in the recommendations, but kids and adults tend to have a little bit different infections, a little bit different incidence of bacterial cause for common infections, and sometimes the antibiotic recommendations differ. So there are adult and pediatric versions of these compendia. And I think in my search for what is the easiest to use, this is probably the most easy to use single source for common infections. And it's put out by the New York State Department of Health. The URL at the bottom, you could directly download this. You would print it on whatever paper stock you wanted to. It has 4 folds in it, and it folds down to about 4.5 by 6.5 inch size. You can keep it in your pocket. It's very easy. If you email Mary Beth Wenger at the email address there, she can actually send you one or more of these that have a little bit of a lamination to them that actually still allow them to be folded, but make them last for years and years. So if she's available, she works at the New York State Department of Health, and she can get you these. Okay, what do we want to do? I'll get into some specifics, but in general, what we want to do is have the right diagnosis, the right drug, the right dosage, and the right duration. And to do all that, we need to make sure that we're diagnosing patients correctly, and specifically, sore throat is not a diagnosis. Viral pharyngitis or strep pharyngitis or some other specific diagnosis is what we should strive for every time we see a patient. Ear pain also is not necessarily a bacterial diagnosis. A patient could have serous otitis media, barotitis, or acute infectious otitis media. We need to be specific with our diagnoses to know that the antibiotics are necessary in those cases. We're getting luckier and luckier, more and more objective tests that we can use, that we can utilize in patients to confirm whether an infection is bacterial or viral. We need to use those when appropriate. And what I found is that a lot of times the patient is accepting of that. If they come in with a sore throat and they think they have strep, you look in their throat and you think it's probably not strep, or some other situation leads you to believe that. For some reason, you get that negative strep test, and people are more accepting of it. So using these tests can help us do the right thing and actually help patients accept us doing the right thing. I think in addition to considering the harms of inappropriate antibiotic prescription, even when we prescribe it appropriately, we need to consider the downside and actually advise the patient that, hey, you need this antibiotic for this infection. It's very likely to help you, but there's still a downside. That can actually help the next time a patient is looking for an antibiotic, because they've been reminded that the antibiotic is not all good. Of course, staying current with the current clinical practice guidelines is indicative of the highest quality practice. Again, to kind of combat that peer pressure, we need to make sure that our colleagues are doing the same thing and understanding what the current guidelines are. educating our patients is certainly important in general, and again, the subject of a little more complicated discussion. And then finally, we do hold the key to prescriptions as medical providers, but I think we need to start thinking of ourselves a lot more as diagnosers and educators versus prescribers. Many conditions get better really without any specific treatment, and prescriptions may help a person feel better. Certainly they are considered helpful in situations of moderate to severe bacterial infection. But again, I think reframing our role as a diagnoser and educator may help this effort take off. Again, reviewing, we want to diagnose correctly, want to make sure that the antimicrobial agent we're using has the appropriate spectrum for the infection, make sure that the dosage is correct, that the duration is correct, and I think overall, we want to be sure that we're not doing the right thing. We want to try to be different. We want to be current with our practice. We want to be consistent, do similar high-quality practices over and over again, and then certainly spread the word. Most of what I'm going to be talking about in terms of these recommendations have to do with the majority of our patients. They're basically medically well. They're not showing signs of toxicity. Their vital signs, maybe apart from fever and a little bit of tachycardia, are normal and they're stable. They don't have signs of systemic inflammatory response syndrome, altered mental status, tachypnea, those sorts of things, the QSOFA criteria. If a patient's really sick, that's not the one to be super stewardish about. Patients who have comorbidities, again, they're generally going to present more ill, but even when they don't, if the patient is immunosuppressed, on dialysis, if they have connective tissue disease or being treated for cancer, those patients need to be considered a little bit more carefully in terms of the risks and benefits of antibiotics. And then among the list of things I'm going to talk about are some significant infections. Patients die of pneumonia and pyelonephritis every year. And so it's important for us to be a little bit more careful with those patients. Those aren't the ones necessarily to forego antibiotics, but those are the ones to make sure that the antibiotic choices and the duration is correct. Okay. Talking about otitis media, there are criteria for otitis media. It's not just a kid with a fever tugging on his ears. We want to make sure that there are history and exam findings to support the diagnosis. Basically, there should be some ear pain and an abnormal tympanic membrane. Do not diagnose acute otitis media if there's no fluid in the middle ear. I think most of us make a visual diagnosis. The guidelines do talk about pneumatic otoscopy or tympanometry. But I think in general, if there's no fluid in the middle ear, it's just a red TM, that is not necessarily otitis media. There's some photos from the guideline that talk about the appearance of what otitis media should look like when you're making the diagnosis. The guidelines in terms of the when to treat with antibiotics and how long you want to treat for, what the appropriate duration is, do depend on the bilaterality or unilaterality, the severity, and the age of the child. Basically, you want to treat when the child is younger, 6 months or younger, if they have severe otitis media. And in that older age range, 6 to 23 months, if you have bilateral acute otitis media, that patient's probably going to benefit more than be harmed from antibiotics. And then when you start to get 24 months or older with a non-severe acute otitis media, or a younger child with unilateral, again, not bilateral and not severe acute otitis media, those patients can be, parents can be offered an antibiotic for the child, but there's also an option for watchful waiting as long as there's follow-up available. You can actually spare antibiotic treatment in those situations. If you are going to treat with antibiotics, a little trouble advancing. Oh, there we go. We have to make sure that the pain, whether the patient's being observed or treated with antibiotics, to make sure that they're being treated for pain. Again, the duration is based on the age. Younger patients are treated for a longer period of time. And amoxicillin has been first-line treatment for acute otitis media forever, and it still is. We do treat with the higher dose of 80 to 90 milligrams per kilogram per day. That's provided BID for amoxicillin. In situations where the child has received an antibiotic within the last 30 days, or they've had a previous failure with amoxicillin, or there's signs of that there might be Haemophilus influenza as the cause, and that would be concurrent to like conjunctivitis, then it's reasonable to bump up and go with the broader spectrum of amoxicillin clavulanate at a similar dose for the amoxicillin component. Second-line medications include cephalosporins and clindamycin if the patient is truly penicillin allergic. And then recently falling off the guidelines is the use of azithromycin, clarithromycin, macrolide antibiotics for acute otitis media because of rising strep pneumo resistance to those antibiotics. Sinusitis actually has been written up as one of the most common diagnosis leading to overprescription. It's really hard to diagnose sinusitis. A lot of patients present with sinus symptoms that don't necessarily indicate a bacterial infection. Really no history, historical element, or physical exam finding is highly sensitive or highly specific for acute sinusitis. Actually, the one with the highest sensitivity and specificity combined is the double thickening phenomenon of the patient having URI and then developing some sinus symptoms. In terms of making that correct diagnosis, if the patient has severe symptoms or persistent symptoms for more than 10 days or has that double thickening phenomenon, then the guideline recommendation is to offer antibiotics. There are some risk factors for resistance. Again, strep pneumo is one of the more commonly causative bacterial organisms. And in the very young and the very old, or if the penicillin non-sensitive strep rate in your community is greater than 10%, or if the patient has other comorbidities or immunocompromised, it's going to be a little more aggressive with treatment. These are the first line and second line antibiotic choices. Amoxicillin clavulanate at the lower dose is first line, recommended by the IDSA. And then when there are those resistance factors, you're going to consider one of the second line agents here. That was for children, and then this is for adult patients. So similar, some overlap. The duration of therapy for adults. This is something where the 2012 guidelines somewhat revised things. So like previously, longer durations of treatment were recommended, but now plenty of evidence that 5 to 7 day treatment for acute sinusitis in adults is adequate. The recommendation for children is still a little bit longer, up to 2 weeks. Macrolides are considered ineffective, as well as trimethoprim sulfamethoxazole, and second generation or third generation cephalosporins no longer considered first or second line treatment for sinusitis. It's probably the case that topical or oral decongestants or antihistamines don't hasten the improvement of acute sinusitis, although they may help the patient's symptoms. And then intranasal saline irrigations and intranasal steroids may help. Steroids are particularly helpful if the patient has a history of acute rhinitis, whether it was rhinitis or a URI that led to the sinusitis. When do we want to treat acute bronchitis with antibiotics? Really, almost never. There was some evidence about 10 years ago of a selected group of patients was reported in the British Medical Journal in 2007. And there was some evidence that if you took patients who were over age 65, that about 1 in 39 were helped by the antibiotic. Basically, quote, did not progress to pneumonia or develop a complication. You know, I think 10 years ago, a number needed to treat of 39 was something that was considered reasonable. But I think what's happened in the last 10 years with rising antimicrobial resistance is that this piece of data, which I think a lot of people have used as a substantiation for treating elderly patients, is probably no longer valid. A healthy elderly patient without comorbidities or chronic lung disease probably will not benefit from antibiotics. Or if they do benefit, they're more likely to be harmed by those. And so the balance is to not prescribe for elderly patients with uncomplicated bronchitis when they're healthy. Patients with chronic lung disease, bronchiectasis, COPD, do benefit in certain situations when they develop acute bronchitis. And of course, I think our main goal is when you have a patient with cough illness is to try and find those more complicated conditions, really screen and study the patient to make sure that they don't have pneumonia. And then when outbreaks occur, pertussis is something that presents as a cough illness that benefits from antibiotics. There's actually, we could talk an hour for pertussis, but it's one of those overlap conditions where it's important to consider in certain situations. Most patients are going to be miserable with their cough illness, so it's reasonable to recommend a variety of treatments for them. Unfortunately, except if there's a little bit of wheezing or some evidence of bronchospasm, not that much helps. In those situations where there is some wheezing or some signs of bronchospasm, like the patient takes a deep breath or talks and coughs immediately, then a beta agonist inhaler can help relieve that symptom. Most of the time you're treating fever and discomfort in general. Again, not a whole lot of study evidence that these things improve, but patients do want to do something, so offering a variety of symptomatic relief is generally recommended for this. What I tend to do is to ask patients if they've been helped by a particular product in the past, and if they were and they didn't have any side effects, then it's certainly reasonable for them to continue that. In situations where pertussis is prevalent, typically there'll be some county health department or state health department guidelines in terms of how to test and whom to treat. And in those situations, macrolide antibiotics and trimethoprim sulfamethoxazole offer the best focused spectrum treatment for pertussis. And then when you're talking about those patients with chronic lung disease that you're going to treat, and again, asthma is a chronic lung disease that does not require antibiotics when it's an exacerbation, unless there's pneumonia. But conditions like bronchiectasis or acute bacterial exacerbation of chronic bronchitis, those patients generally do require antibiotics if there's sputum change or shortness of breath or fever, even with a clear chest X-ray. But for those patients, simple antibiotics still do the trick. So something like amoxicillin, trimethoprim sulfamethoxazole, or doxycycline are very reasonable. And those simple choices are actually supported by the most recent GOLD guidelines. Those come out every year or two. Voluminous, hundreds of pages of information about caring for patients with COPD. But again, simple antibiotics are very reasonable for those patients with acute bronchitis. Pharyngitis, most patients with sore throat are not going to have strep. The viruses are going to be the cause. Again, this is going to differ based on age group, but in general, over half of the patients that we see with sore throat are not going to have strep, not going to require an antibiotic. There's an objective test for acute pharyngitis, several different ones that are generally pretty reliable. You don't have to test and probably shouldn't test everyone with a sore throat because false positive tests do occur. So you want to look at the history and the exam. The central criteria, the Centaur scale, is one of the sort of risk stratification tools that's available. When there's fever and anterior cervical lymphadenopathy, exudates of the tonsils of the pharynx, and there aren't other viral type symptoms like nasal congestion or cough, the more of these the patient has, the higher the chance of strep. A few years ago, it was recommended that if a patient had 3 or 4 of these, they could be treated empirically with antibiotics and not have a rapid strep test done. But currently, having 3 or 4 of these is felt to be the criteria to do a rapid strep, and then base your treatment on the test. Again, making that correct diagnosis is choosing whom to test, and then once you have a patient with that high pretest probability plus a positive rapid strep test, it's reasonable to treat them. For pediatric patients, if there's a high pretest probability but a negative rapid test, it's recommended that be followed up with a throat culture. There are no recommendations to treat while awaiting throat culture. That is one of the older practices, and it's not necessary and does result in excessive inappropriate prescription. Also, a reminder just to keep in mind that other things do cause strep throat and do cause sore throat or pharyngeal infection. I think our main value in evaluating patients with sore throats is treating strep appropriately and not excessively, and also considering these other rarer causes like peritonsil abscess or a patient who might have gonorrhea or diphtheria, which is extremely rare, or maybe a mycoplasma syndrome or mononucleosis. Treatment is still very simple. Penicillin, either IM or PO, is first line. Because of the poor palatability of oral penicillin liquid for children, there are options to treat with amoxicillin or first-generation cephalosporins. These are patients who do not require broad-spectrum antibiotics like fluoroquinolones or amoxicillin clavulanic acid. There's really no treatment recommendation or evidence-based guideline to treat with those broader-spectrum antibiotics. If you have a patient that you think has peritonsillar cellulitis, then something like amoxicillin clavulanate may be reasonable. That's a different infection than strep throat, and there are certainly some other more complicated throat infections that can occur, but in our run-of-the-mill sore throat, is the strep or not, penicillin or other narrow-spectrum antibiotics are still first line and second line. Macrolides can be considered in penicillin allergic patients as well as clindamycin. This is taken from the IDSA guideline. It is the pediatric recommendations. Pneumonia. So, how do we make the diagnosis of pneumonia? Chest X-ray is considered the gold standard. This patient has right middle lobe pneumonia. Not absolutely necessary to do a chest X-ray, although you don't want to overdiagnose. I think in children, the tendency is to make a clinical diagnosis or maybe get a 1D chest film to confirm an infiltrate. I think in those situations where a patient is very ill, it's probably good to get a chest film to see how extensive the pneumonia is, whether it's more than one lobe involvement, because that can affect the disposition of the patient. But most simple pneumonias, you're going to suspect based on physical exam, and then you can confirm with chest film in teenagers and adults. And it's nice to have that objective test results to know that you are treating the patient appropriately. You want to make sure that you cover for strep pneumo and for atypical organisms like mycoplasma and chlamydophila. There are some risk factors for resistant strep, which are listed on the slide. Now, these guidelines come from 2007, so they're about 10 years old, a little over 10 years old, and they are due to be updated. And I think they probably will significantly change because of rising macrolide resistance. I think what we're seeing now is some of the acute care infectious disease specialists recommending treatment with a macrolide, like azithromycin, clarithromycin, or erythromycin, or doxy, and then in addition adding beta-lactam because of rising strep pneumo resistance to azithromycin. But the guideline-based recommendation is in a previously healthy patient with no risk factors for resistance that probably a macrolide or doxycycline is reasonable for adults. When there are those risk factors for resistance, then again, using a macrolide plus something like high-dose amoxicillin or amoxicillin clavulanate, or that, again, combination of macrolide or doxy plus second-generation cephalosporin is really recommended when there are risk factors, and I think the recommendation may be in the future to do this for most patients. Fluoroquinolones in 2007 were perfect, or felt to be perfect for the treatment of pneumonia in a more complicated situation, but there's more and more concern about the collateral damage caused by these antibiotics, so they first-line treatments or first-line guideline-based recommended treatments for patients with risk factors or more complicated situations in the future, but we'll see what the recommendations show. You want to treat for at least 5 days. Of course, azithromycin and levo are actually packaged or commonly prescribed in those 5-day courses, and that is fine for pneumonia. You want to take, again, pneumonia is one of those more significant bacterial infections, so you want to take some clinical criteria also into account. You want to make sure that by the time the patient is finishing their antibiotics, that they've been afebrile for 2 or 3 days, and they should really be looking well by that point. A lot of patients still have some shortness of breath for several weeks after recovering from pneumonia, but they shouldn't have vital sign abnormalities or pulse ox abnormalities. They should be looking fairly well by the time that minimum 5-day antibiotic course is being finished up. And if not, then it would be a reason to treat them for a bit longer. In children, the recommendations are still similar for a long time to use just plain old amoxicillin in that higher dose, 90 milligrams per kilogram per day. That's going to be first line in most kids with mild to moderate pneumonia. Kids with worse than moderate pneumonia are probably going to need to be hospitalized. Macrolides are only recommended if there are signs of atypical disease, which would be kind of an infiltrate that's a little bit patchier and dense consolidation. But this is actually a difficult call to make. Moving on to acute cystitis. We give a long talk again about the asymptomatic pyuria, asymptomatic bacteriuria. In general, in acute care practice, patients are going to be coming to us with symptoms. They're going to have dysuria, urgency, and frequency, or worse than that, like those symptoms and or fever, flank pain, or flank tenderness to percussion. Those are going to be the symptoms that are going to make you think that the patient has a urinary tract infection. They're going to have they don't necessarily need to have objective findings on tests. The pretest probability of a patient with typical urinary tract infection symptoms is quite high, but you're going to be reassured that you're making the correct diagnosis if on urine dipstick they have leukocyte esterase or nitrates, their nitrates are positive. If on microscopic exam they're greater than 10 white cells for adults or greater than 4 white cells for 5 white cells for high-part field for children, it's going to increase your confidence in the diagnosis of the UTI in that patient. When culture is obtained, there are different thresholds for adults and children. Culture is not necessary for the diagnosis. In most cases, it can help confirm the diagnosis in certain cases, and then certainly once you have culture results, you can know the exact correct antibiotic to use. I'll talk about empiric therapy in a second. The diagnosis the real specific diagnosis of urinary tract infection in children can be quite complicated. This slide summarizes it. And if you don't have a knowledge, if you see children need to diagnose urinary tract infection in them and don't have this sort of an algorithm, at least basically in your mind, the resource on the slide by Blake White in the American Family Physician is a good resource, and this comes directly from that. Fairly simple antibiotics are used for treating urinary tract infection in adults. Nitrofurantoin, very basic antibiotic, 100 milligrams BID for 5 days. Trimethoprim sulfamethoxazole is still useful if the rate of E. coli resistance to it is less than 20% in your community. You can get antibiograms typically from the laboratory of the nearest hospital to you, and it will be a pretty good representation of the rates of antibiotic resistance in your community. Fosfomycin is in the guidelines. I don't see this used that much, but it is viable single-dose therapy. I think it tends to be fairly expensive, but it is, guideline-based. Certainly would be narrow spectrum and quick duration, so, appealing from antibiotic stewardship guideline perspective. Pivnacillinam is an antibiotic that is not available in the United States yet, and I'm not sure that it will be, but it's another 5-day course of a relatively narrow spectrum antibiotic that works and is recommended for urinary tract infection in healthy adults. The UTI guidelines from 2011, so probably won't be revised soon. It does include a recommendation for a 3-day course of fluoroquinolones in situations where there's either allergy history or other factors would make you not use one of those first-line agents. Beta-lactams are also a viable option. I think the current sort of state-of-the-art for fluoroquinolones is that they may be used when nothing else is useful, and this is empiric therapy. In situations where that fluoroquinolone resistance is less than 10%, again, this is for pyelonephritis, so again, a more significant infection. Fluoroquinolones are certainly worth the risk, worth the collateral damage in these situations, and you would want to use these agents when, in most situations for empiric therapy for pyelo, you're going to have the urine culture result in a couple of days that could guide your therapy afterwards. When fluoroquinolone resistance is less than 10%, there's an option to give an IV dose of a medication initially, either an aminoglycoside or ceftriaxone. In situations where the fluoroquinolone resistance for E. coli is greater than 10%, that initial dose is actually going to be somewhat mandatory in that situation. And then I think we don't use aminoglycosides in urgent care, but those are options in other settings where those medications would be available to you. And then, again, I think that trimethoprim sulfamethoxazole is an option if you feel confident that the organism is susceptible. And again, if you know with a culture result that an organism is susceptible, you can pick the best agent once that culture is available. Urinary tract infection in children, a little bit different. Antibiotic regimens, nitrofurantoin is not necessarily used in children. Amoxicillin clavulanate and trimethoprim sulfamethoxazole or Zolagus cephalosporins are still reasonable. I think in our group we tend to use cephalexin first line in children, and cultures in children are important. So they're obtained in all kids with UTI or possible UTI, and those are going to be helpful a couple days down the road when the results are available. Finally, skin and soft tissue infections. Even though community-acquired MRSA is increasing, generally it does not need to be covered unless there's some purulence, either purulent drainage or an abscess. So you're going to mostly want to keep it simple and cover for MSSA and strep. I'll talk about those antibiotics in a moment. In situations where you have an abscess that's isolated, incision and drainage may be the only thing that you have to do. If there's an associated cellulitis or the patient is systemically ill or you have immunocompromised, you would add some antibiotics in that case with MRSA coverage. 5-day duration of therapy is recommended, and for the variety of skin and soft tissue infections that can occur, syphilis, a non-purulent skin and soft tissue infection, I think most prescribers are using cephalexin or dicloxacillin. When you have MRSA, then a doxycycline type antibiotic or trimethoprim sulfamethoxazole can be used or added to your MSSA strep coverage. Now, low-hanging fruit. Think of situations where you have clean wounds or even most bite wounds. For years, I've known people who have prescribed antibiotics in those situations. They're really not necessary. Fluoroquinolones are not needed as first line for simple acute sinusitis, bronchitis, COPD exacerbation. I think for many years, a 3-day course of ciprofloxacin was recommended for most patients with diarrhea, and that has fallen off the list, no longer necessary, should not be done. If you have a simple abscess that you can adequately drain, antibiotics are not needed. If you've had the nose for epistaxis, the packing should come out in 3 days, and there's really no need to prescribe antibiotic prophylaxis for sinusitis. In patients with reactive airways disease, in children with bronchiolitis, and in adults and children with uncomplicated influenza, you need to treat the influenza, but no antibiotics are needed. either prophylactically or to treat that patient unless you have a documented bacterial infection. When patients have tooth pain and no abscess or obvious infection, antibiotics are not helpful and not needed in those situations. And then in situations where a generally healthy patient has an outer ear infection, otitis externa, they can be treated with topical medications, topical antibiotics adequately, and they do not require oral antibiotics. How do we make patients happy with this? I think we need to explain the harms, even in situations where the antibiotic is needed, and mention to patients that they may exceed the benefit. There's a number needed to treat, meaning that not everybody who takes an antibiotic actually gets the benefit, and there's a number needed to harm, meaning that of those who take antibiotics, some people will be harmed. I think for some patients who are used to getting antibiotics, it's actually a good idea to explain to them that this is something new. What we're doing now, not giving antibiotics, is based on new science, new knowledge. Every so often there are stories in the media about these superbugs, and it's certainly reasonable to weave those in, say, hey, you're in a situation where you don't need an antibiotic. I don't know if you've seen the stories about these highly resistant organisms and all the damage they're causing and the harm that they can cause to individuals and society. Certainly, we should be offering symptomatic treatments, pain relief, fever relief, symptom management to all of these patients. Want to make sure that if the situation changes, that the patient does have easy access to follow-up. Make sure that we're answering all those questions and not just refusing to prescribe an antibiotic. We're there to care for the patient, not just make a decision about whether they get an antibiotic or not. Safety net prescription seems like a cop-out, but it's actually very good data for otitis media and sinusitis that this is reasonable. And in any situation where you're getting some pushback from a patient in those other situations, let's say, like bronchitis, hard to be perfect 100% of the time, but there's good data that giving a patient an antibiotic that's post-dated for a couple of days, they have a little bit of security, and many times they won't fill it. So you're accomplishing a goal, kind of somewhat with a compromise, but it's a reasonable compromise in those situations, and it may help kind of maintain patient satisfaction in those situations. A little bit of scripting, these are some things that I found are generally effective. Tell a patient, kind of put the ball back in their court and say, if you're the type of person who doesn't like to take antibiotics unless you absolutely have to, why don't you just wait and see how you feel? Emphasizing that even in situations where an antibiotic is prescribed, the immune system is actually doing most of the work. And then again, emphasizing that there's a downside to taking antibiotics even when the patient expects to be cured by it. Doing that in situations where they receive an antibiotic is as important as telling them that when they don't. Having brochures and pamphlets available for patients to emphasize the fact that antibiotics are not needed every time they get sick or helpful. This comes from the California Aware Foundation. It's available on that URL web link, or you can request these to be mailed from you if you contact Aware directly. These are for adults and kids. They're front and back. These are some that are available from the CDC. These can be downloaded in a lot better definition, a lot higher definition than I have here, but they're just examples of what's available. So finally, just to summarize, I hope everybody understands that antibiotic resistance is related to our prescribing habits, both appropriate and inappropriate prescriptions. I talked a lot about what the antibiotic guidelines are, but most patients with respiratory tract infections, you don't even need to get into it because most respiratory tract infections are going to be viral. Screen for bacterial illnesses, and then explain to patients that they don't need antibiotics for viruses. Patient education is a very big part of this. I think that's how we're going to get things to change. I think probably physicians and other providers are more willing to change maybe than patients are, or that's our perception. So we really have to start educating patients, starting now and into the future about this. And again, that's going to be the topic of the December 11th webinar, so I invite you to attend that. Make sure you're being very specific and not casual with your diagnoses. Categorize patients' illnesses based on their comorbidities and risk factors and whether they're bacterial or viral. When you do pull the trigger on antibiotics, you want to make sure that you're not using an agent that has a broader spectrum than needed or a duration that's longer than needed. And then certainly, as you are now, make sure that you stay up to date with clinical practice guidelines. These are revised periodically, and sometimes they do change significantly. I think we're going to see a significant change in the adult pneumonia guideline when it's revised, and I believe the next UTI guideline will probably be significantly different in terms of the use of fluoroquinolones, both as an option for uncomplicated cystitis and as well for pyelonephritis. The last few slides are direct references for the information that is contained in the other slides. I thank you very much for participating.
Excellent. Thank you. If you could actually pass me the ball back, Dr. Toscano, I'm just going to finish up with a few closing remarks. Perfect. All right. So from this side, you can see our contact information for New England. If you have any questions, you can directly contact your state lead. The next few slides show the contact information if you live outside of New England. Obviously, if you aren't sure who to contact, you can always reach out to us and we will get you pointed in the right direction. Also, here's the contact information for Carla at the Urgent Care Association if you want to reach out directly with any questions. As we mentioned at the beginning of the presentation, and then Dr. Toscano just mentioned, our next webinar is on December 11th. We have changed the time. It's going to be from 12 p.m. to 1 p.m. Eastern Time. So be on the lookout for registration information on that presentation. And the Learning Center is our virtual learning system which hosts free courses for all healthcare settings. Our goal is to educate providers and help them improve the quality, efficiency, and value of healthcare. You can create your own account by visiting www.learning4quality.org and find your registration code for your healthcare settings. If you have any questions about the Learning Center, you can email us at learning@healthcentricadvisors.org for assistance. Our next slide, we are on social media. So please connect with us on Facebook, LinkedIn, Twitter, and Instagram for the latest resources, webinars, and other offerings from the New England QIO. With that, again, thank you for a great presentation, and we look forward to having you join us for our next webinar. Bye, everybody. Thank you. Excellent. Thank you, Dr. Toscano, for redoing this with us. Hopefully we won't have to do that next time.
That sounds okay. Whatever we have to do. Thanks for your help.
And we are all set for that 12 to 1 p.m. time slot Eastern Time.
Yeah. Perfect.
So I'm glad we got that straightened out before we emailed everyone.
Yeah.
So that's good to go.
Yep.
And is there anything else you need from us?
I don't think so. I think we're good. I'm good.
I think Francis was waiting on a day to potentially do a dry run for the next one, but depending on your feeling,